Hi, my name is Mark Abrams. I'm here to talk to you about endoscopic SPG blocks and other blocks that you can use to treat and manage migraine patients with, but other disorders as well. I've been doing these for the past 5 years and learned because I'm a patient that has migraines and also working with migraine doctors for many years that were doing sphenocasts and other things like that. I got fascinated in these and started doing them after I saw a lot of migraine patients that emerged after COVID-19, me included. And there's a lot of good literature out there to explain why this occurs. And I'll try to tell you a little bit of what I've learned about that and the rest of the story. The story that we don't learn when we ignore what happens when we just use the local anesthetic to turn off the pain. We use these blocks to prep the nose, and you heard about that in the first part of the course. But really, what we tend to sort of overlook is the effect of actually removing the pain completely in these areas for a period of time long enough for the system to sort of reboot. So I'll tell you what we find out, and I'll get this story told hopefully relatively efficiently because it takes about 30 minutes to go through this data, but there's a lot to talk about. And so we'll leave questions for you to email me about or ask at the end of the talk if you're here listening to it. So it is the course objectives. Basically, nerve blocks, we know they work. They've been doing things for a long time, and we know how local anesthetic works. We just need to teach doctors that do these kind of patient care to be able to do these better. So endoscopically, as nose doctors, we can actually do these probably better than anybody because we can see what we're doing and lend our expertise to this area. Finally, once we do them, we see that they actually work pretty well, and how they can be used is then the next thing we need to do. Figure out what to do and then how well they work. I'll tell you about that because we did a little bit of a write-up on this. And then finally, once you've done that, you need to know who to target and what you can tell by doing them diagnostically to the patient. Then finally, the nose, jaw, and neck will also have impact on this. And you can profile your patients essentially at the doorway, and you can probably anticipate whether they are at risk for migraine. Because we see these patients all the time. We should be good at this too, because we are the nasal anatomy experts, and we work in the nose for a living, and we're doing endoscopy in our daily life. We scope people all the time in the office, so we sort of set up for it. And so we see these patients because these are the patients that aren't good at this to see other providers and miss the diagnosis. We know this because of the classic SAM study most of us heard about in journal clubs. That was an excellent study done where they looked at 100 sinus headache patients that thought they had sinus infections. In fact, their referring doctors did most of the time too, and they had them see true experts in a real workup with allergists, ENT, and neurology, rendering their diagnosis and evaluations, including CT. But only 3%, the judge and jury all in one, had acute sinusitis or any sign of sinusitis on CT scan and imaging. So what that means is only 3% got it right that were actually thinking they had a sinus infection. But the doctors were wrong almost 80% of the time as well, which tells you as humanity, we're not very good at this. And they did another larger volume study in 2004, earlier than that, that showed why this happens. Because this is a great sinus infection Halloween costume. Patients have pain in the right place, but there's also drainage, there's also swelling in the nose and in the eye and in the back of the mouth because that's what they do. The phenolphthalein blocks this response that's acutely created when you have sinus pressure by lighting up the SPG, phenolphthalein ganglion. There's a lot of parasympathetic fibers that get released when that gets triggered to the reflex. So we see these patients. They're the ones that think they don't have a migraine. They think they have a sinus infection. They think they have an ear infection that's not getting better because their ear is aching from their TMD and they got a headache in their temple. They also got weird sounds in their ears. They have amped up tinnitus, clicking in their ears, red ears, draining ears that aren't draining, and all this other stuff. These, patients think they have vertigo, and then the patients that also have the other symptoms in their nose where they're having dysosmia, particularly after COVID. So these patients are complicated. They all come to see us because they're frustrated, scared, or misdiagnosed. We do the whole evaluation, including CT, endoscopy, audios, Hallmarks, all this stuff helpful, but if you find something. But if you don't, then you're stuck. You say, listen, I think you had a migraine. You don't have any of these other things. So do you want to try these neurologic medications that I've tried some, but really don't use that much? Or do you want to see a neurologist, but they're booked out 6 months? So they're sort of stuck, and we're stuck in a bad conversation. And these patients have many difficult explaining symptoms as well that we just try to explain away, but really don't have a great answer. Things like the amplified tinnitus, the patient that comes in with transient hearing loss and their hearing test is normal, hyperacusis, the patient thinks there's something crawling in their ear. Here, yeah, it's a migraine aura. in these patients. Myoclonic type ear symptoms, also olfactory brain farts. They have phantom smells and they don't smell after COVID. Very common now. Vascular symptoms. The patient has unilateral swelling or facial flushing. You don't wonder what's going on. Autoimmune stuff, maybe, yeah, but it's not common. Here again, relapsing polychondritis, not very common in the ear, but migraines make the ears red. And then you also have dysautonomia and other things. And this is difficult because this is a frustrating process trying to figure these things out. There's not a real good roadmap, symptom wise or imaging, that's going to help you. You rule out the bad things, but you don't find what the real answer is. So, this is not going away because they're already common. Then COVID came along, took the sixth most common chronic illness and made it almost doubly impactful and doubly common. And then this happened even more after the vaccines. Not that the vaccine was the problem, it's just the target, the ACE2 receptor. The ACE2 receptor turns on more than bad things and it gets bound and almost kills you. But what happens is you don't have to have a bad case of COVID to get long COVID. And the ACE2 is the brakes on your inflammation, clotting, and heart inotropy, and kappa pain regulation. All those things get dysregulated going afterwards in patients that are already dysregulated. Patients have inflammation, other neuropsych disorders, and other things. Because what it does is it creates a huge impact of neuroinflammation. And that's basically run by the molecule CGRP. And you'll hear about that with migraines a lot, the CGRP inhibitors like Nurtec, Ubrelvy, Qulipta, and the shots for that. They're very helpful, and it's good to get well versed in that if you see migraine patients. They're finally getting where they can be first line in some settings. But these are very debilitated patients. This is the third highest morbidity of a chronic illness. They have much to learn, and so do we. We still don't understand migraines completely, but they need to be taught about how they work. And then physical findings, there's not much there. You're diagnosing the patient basically by what they're telling you what's going on in their head most of the time. And that's difficult because you're sort of trying to figure it out, but you don't have a lot to go with from a diagnostic standpoint. But there are things you can look for, and I'll teach you that. These are very good tools once you learn them, and it gives you a better approach. So the problematic thing we have to deal with is the definition to begin with. I love my neurology friends, and I have to be very careful when I talk about this because I don't want to poo-poo what they're saying to us because they really own the condition, and thank God they do because this is difficult. And they're smart people. The problem is they were under duress when they made the definitions. They were told by Medicare the definition of a stroke. Apparently, that's how it worked. The whole story is, and they had to get together and create a diagnostic criteria for migraine so you could differentiate the two because you can have both honestly, but you can have basically this sort of diagnostic criteria that sort of keeps you sort of in something you do research on and also make a category that can also be Medicare approved as well. So here we are, recurring symptoms that last 4 to 72 hours with a headache that has two of the four characteristics here, multiple choice question, unilateral, pulsatile. That's not necessarily the case. Actually, most common is bilateral. Actually, moderate to severe pain. Yeah, okay, you get a migraine without a headache. It's the inocular migraine. Also, it can be aggravated or causing avoidance of routine physical activity. That's my daily life. So I'm not sure that's very specific. And then you add on the fact that you have to have two other things to sort of clinch the diagnosis. But basically, we have is a nausea or vomiting or photophobia, diagnostic category as well. And so what that leaves you with is basically a diagnosis that's fairly stereotypical, narrow, and it's a diagnosis of exclusion. So what happens when you see these patients that don't fit that box? They're very common. And what you need to sort of describe is what this is something that might be a migraine, because migraines happen to a lot of people. It's basically programming how other animals even do these. It's a neurologic overload event. There's really three different types. We'll talk about that in a minute. But basically, the brain's being overwhelmed by something that breaks this threshold, and it's a 3-day event, not just a 2 or 3 hour headache. Has a prodrome, has an aura, has an inhibition point, and then when the attack occurs, and then there's a prodrome, postdrome, like a hangover. And so what happens is you get an overload of a brain's homeostatic state by neurologic stress. And the homeostatic state is maintained by two things. The genes you got that allows you to maintain that easier, more difficult, those are mutations of ion channels and neurochemistry. And then there's other acquired disease states that can affect that. Things like vascular disease, things like infections that you've had, things like trauma and toxins, but also lifestyle. We got to maintain our brain. We got to give it full fuel. We got to give it water. We got to give it sleep. and we got to maintain our hormonal and nutritional balance. So these are things that are difficult for people to do that are busy. And over time, it becomes impactful. And then the neurologic stressors are central and peripheral as well. Things inside the head, like emotions, like hormonal dysfunction, like disease states that give us headaches, and then infections can do it, and so can CSF barometric changes. We can't get off the planet, but when the weather changes, we sure know it if we have migraines. And then peripheral things, those are the things that turn on the brainstem and break the fuse through pain, things from the front and the back of the head, our nose and sinuses, our jaws that have to live with them, and our necks that also have to continue to look down at computer screens and sleep on their side in these particular patients. So what happens? It breaks the system down in an overload event that creates an attack that's either led by cortical depression, causing a decrease in function, followed by an attack where there's inhibition, or a seizure, which it hypolarizes once it breaks that threshold and goes off the rails. And then you can also have stroke as an overload event when the vascular system to that area also gets overloaded by the attacks that's created by this process. And that can happen in events with migraine or seizure. You can have stroke. So you see impact on MRIs of that, the white matter disease you see in these brains. So what happens is management is difficult because you have to do more than one thing. You got to maintain their homeostasis, you got to improve their neurochemical balance, and you got to reboot their maladaptive pathways so they can actually work back to normal. But that's hard to do unless you can catch up real fast. And that's why blocks make sense because changing people's lifestyle is difficult. Getting people to drink water, that's guys. Most of us are busy, but we're bad at that. The girls aren't great to eat breakfast. And then, hate to stereotype that, but that's what I see every day. And it's one of the ways you can sort of start coaching. You sort of suspect these things. Mediterranean diet, best diet you can. You can't periodic fast with migraines. You starve your brain, gets a headache. And then you need to go ahead and supplement the food that over time we start becoming deficient in once we live past our life's expectancy based on its design. We know this. Anthropologists told us this. We're made to actually live to age 38, but we should have known it because the historians already knew that. That was a life expectancy before 1850, before modern medicine allowed us to create a life that lives in a body that wasn't evolved to do that. And then, so we got to sleep. We got to recharge the battery. And that's live a circadian life. We got to get up, eat food, get sunlight, and go to bed at night. Be night owls. Otherwise, we wind up becoming neurochemically imbalanced, and that happens. That's through, changes in our serotonin, and our it goes down. Our norepinephrine goes up. Our glutamate, our pain neurotransmitter goes up, and our GABA goes down. So we become more triggered, more anxious, more fight or flight, and we can't sleep because the serotonin is a precursor of melatonin. And then that's when you see chronic migraine change those things. More than two headaches a week is the definition. Then you stabilize ion channels. That's difficult. That's going back to chemistry class and being pharmacists. Neurologists are pretty good at that because that's their life. They have to give pills for a lot of things, and they're good at this because they understand how it impacts things in other parts of the brain too, and they can play that game pretty well because they're good chefs in that regard. We are potential to be the worst cooks in America. So you need to find something that's at least the right stuff made for this. We don't need to go getting crazy and start using seizure and neurologic and psychiatry medicines for patients. We don't treat with that stuff very much. What we do well, if we find something that works as low risk and highly reliable, then we'll do it. CGRP inhibitors is where you really want to go. Nurtec Ubrelvy for turning off the amplification state. And then if you need to go daily, I like Qulipta because I don't require a bunch of, prior authorizations and the patients don't need to get shots. Here again, neurology can do that too, but you want to work with them because they're the best at doing that. But neuromodulation is the way to go if you can do it, if you have the tools. And they've been doing this for a long time and it works. You can anesthetize, you can ablate, you can hyperstimulate nerves, they all work. And there's three different orders of nerve block. First order is the peripheral nerve. Second order is the brainstem to the thalamus. And third order is from the thalamus to the cortex and other things like the mood centers and the awareness centers because those areas are much more complicated. But what is not that complicated is the wiring of the peripheral nervous system. We're all wired the same way. So nerve blocks really are the answer because they're reliable and we can get to them without having to do a lot of fanfare except for inside the nose. But that's what we do well because the other nerve blocks can basically scalp injections. They don't hurt anything really from a downside of negativity from a risk standpoint, except they hurt for a second and people don't really like needles. But they like getting an answer and they love feeling better. And that's why I love the neck blocks because your neck feels great afterwards immediately. You get their attention and they feel better right away. So these are your targets, the circuits from the front and the back of the head. The front of the head, most commonly we talk about sphenopalatine, but we'll talk about the anterethmoid nerve and the auriculotemporal nerve are both equally as impactful. Just the SPG's got more going through it. And then the occipital nerve plexus is something we tend to ignore as otolaryngologists. We pay attention to the front of the head, but ignore the back because they figure that's the C-spine guys. They can have that because there's dangerous stuff back there like the spinal cord and CSF. However, the upper part of the head is free game because if you can hit the nerve more downstream where it's just going over the calvarium, you got nothing to hit but bone there. You're not going to hurt anything and you're not going to skewer the nerve if you're just careful. So that's why blocks are a great idea if you can do them all because you can turn off all the bad fuses in the brainstem. You've really rerouted that part of the system well. And it's just all about accuracy and knowing you got the job done. So let's talk about the targets. The SPG has long been hailed the holy grail of blocks. Greenfield Sluter figured this out back in 1908 when he was just using a head mirror on his face and putting in cocaine, and they used phenol in those cases. Back then, when getting lidocaine eventually came into use. And then Milton Reeder brought it back because pills stopped working for migraines after a while because that's why he sort of Greenfield lost the audience when they came up with Advil and Tylenol. But then they stopped getting better, and then they needed a better approach. And Milton Reeder brought back the SPG and started doing them in Manhattan. Actually, one of his patients that actually really loved him, and I got to hear about that story. Sphenopalatine blocks, though, make sense because they're in a good place for doing a lot of this because it's not just pain of V2 going through there, but you get the parasympathetic and sympathetic systems going through that relay as well. So that gives you a great deal of versatility and other things you can fix. But the approach has been largely invasive or uncomfortable. You either had to go above or below the zygoma and behind the maxilla under the eye. A deep place to go, and using fluoro and long needles required anesthesia and risk because there's vessels back there. So it became expensive and risky. Then they started going inside the nose, but that was a little more indirect because we're trying to rely on the mucosa to deliver medicine to a place through a nerve that we're not really 100% sure is getting there. But they got statistical significance. I met Morris Mizella, did the Q-tip study with lidocaine, and he got published in JAMA. The problem is he didn't get that great a significant effect. It was like 54% compared to 38 or something. So it was a modest improvement, but it has statistical significance and it's a randomized controlled study. That's the things you look at to prove it wasn't placebo. So it wasn't placebo, but it wasn't great. So then it came with these catheters where they can actually squirt the lidocaine in there far enough to get it somewhere where you're a little more certain, but it's still a blind technique. The catheters are low profile, but they're still a little big for these tight noses because they're the ones that get headaches. And then, of course, you got something that's, I think, 2% going back there, and you probably need a little higher dose, and a lot of it's missing the target. So they didn't get quite as good a response. Of course, his end value wasn't as great. And then they started trying endoscopic blocks using the spinal needle. These guys, Rodman and Dutton. And so what happened is you see better results, the better you could be certain you hit the target. 67% with the SPG and stereotactic. Intranasal catheters, they got a trend, but they only had an N number of 41. He's a family practice guy. He was doing the best he could. He's a great guy. I met him. But the Rodman and Dutton group, they really got some good statistical significance and duration in their patients. And they used bupivacaine and triamcinolone, but it was a high percentage of bupivacaine, and they were injecting it. And they're also getting the anterethmoidal nerve, which I think is crucial here because the more you block, the better you do. And that way you get those both done well because they're easy to hit, as you'll see. So, because we've got these tools that we can look in there and we just been sort of wondering, you know, I wonder if this works. I don't know if you've occurred to you to try this, but I did. And I found out they really work if you find a way to get it done. So the key is knowing, first of all, where to go. Up high up in the nose, in front of the head of the middle turbinate, as high up in the vault as you can get is where you put the anterethmoidal nerve cotton balls. I put two up in there because it's really easy to hit. And the one in the back is a much more of a blind, long technique. It's a little uncomfortable, but you can get it there in a well aphronized and lidocained nose with an atomizer. And then you just got to get it back in the corner pocket the best you can. So I'll show you a little video, but these are the targets. Anterethral nerve, what is that doing? It's turning off V1. But it's not just the top half of the nose, because you got this neural axis from the tip of the nose to the middle part of the sphenoid rostrum and everything above that. The upper orbit, the anterior cranial fossa by that matter, frontal sinus, anterethmoid, all gets V1 innervation. And you get the anterior cranial fossa, which is impactful for these frontal headaches. Then you get these SPG, just the other half of the nose, but it also gets upper teeth, palate, and posterior orbit. And you get this co-innervation. It sometimes makes these TMJ patients feel better too because it goes to the same circuit board. And that reduces the tone in their jaws. And so you'll see patients' trismus just with an SPG block get better. But it gets the posterior middle fossa dura as well. And it also has parasympathetic and sympathetic flow. So that's the big thing. So you really see when you have a migraine, you get this sort of parasympathetic storm. They get a runny nose, they get a teary eye, they get mucus and congestion and all that stuff. And when you do this, it really works well for those vasomotor symptoms. Yes, it probably works for vasomotor rhinitis. So when you're doing a, posterior nasal nerve ablation, keep that in mind. You're going to get a little bit of effect from just the local itself. And then SPG, it's a great thing for the sympathetic tone too, because between times the nose tends to be dry and sort of, and the whole body becomes more sympathetically amped up. Just over time, that's what pain does. Higher your lower no, basal norepinephrine and glutamate levels. And so what over time is we get a neurochemical imbalance, and that's why SPGs are really impactful. But then if we leave out the jaw, we're leaving out a very important trigger. That's probably number two on the hit parade is a tight jaw. These are lower jaws that are insufficient, that they're constantly having to work just to try to live with it. Because if your nose is stopped up and your jaw short, your tongue's in the back of your airway, and you have to do a jaw sit up every breath you take, and you can't sleep on your back. Your tongue falls in your airway, so you wind up sleeping on that same side. We'll talk about that, and that's why you'll get the pain behind the jaw, in the ear, and in the temple. And that's where the auriculotemporal nerve, which is easy to hit because it's right in front of the artery and vein, just right in front of the helical root over the zygoma. So occipital nerves, here again, they're impactful because they go to the same circuit board. You'll see on the next slide, the circuit board is called the trigeminal cervical nucleus. And the front and the back of the head have a mirror sort of image. And you'll see the back of the neck is taxed by two things, head forward and shoulder forward posture and sleeping on our side. We look at that, things too long already by just using our hands, but then we add all these screens to our life and it really taxed our body. And then as your airway gets more congested over time, just from many insults, we wind up having to sleep on our side, and we don't do that well. And then what happens is we get impacted by worn out neck muscles that are directly impacting nerves because they go around or through them. The occipital nerve plexus comes out underneath the skull around the lateral process of C2, then it extends back around the SCM and then through the trapezius tendon. So what happens is both these get strained by wore out necks with bad posture. So what happens is the nose tells you a whole story. What happens is if you have a narrow nose, you got to sleep on your side, and you'll sleep on the same side every day because the airway is impacting how you breathe best while you sleep. Because if you have a deviated septum, most of the time the tight side is determined by the septal deviation, and the bad side will be towards the earth because it's impacted less by gravity than the good side because the good side, the turbinates get congested in about 20 minutes if you lay on them long enough. So what happens is most patients stay on that side until it hurts too bad. Then they start going back and forth and ping pong, and then their necks wore out and their sleep's terrible. I know I'm one of them. So what happens we can fix these noses, we can help a lot of things because the nasal anatomy will determine this and also determine the side of the pain and where it hurts. So the nose acts like a tight shoe you can't take off. And if you got a narrow nose, you got a tight shoe. It's like wearing, a tight ski boot. If your socks are too thick or you got bunions, you got pain. And the pain builds over time, particularly as it swells. So that's what's happening. And then we know that you don't have to help it a lot to make a big difference in terms of flow, because the better flow, radius to the fourth power, Seal's law, controls that. So that's why it's so impactful to make the nose work better for breathing. So once we do that, we also unlock the other half of the airway, the jaw. The jaw is always under work when the nose doesn't work, because otherwise our tongue falls in the airway and it gets big because it's having to do a plank against your palate. And the shorter the jaw, the more they're on their side, and the bigger the tongue. Because the tongue has to do a bit more work if it's in the wrong place than having to work harder to get out of the airway. Because then they have increased velocity back in their orifice, pulling their tongue in there, particularly if their hyoid's low as well. So these are usually patients you can profile the doorway. Cute little noses they can't breathe through. They're either narrow or too small for the body they got, and their jaws compounding factors if it's too small, and that's what happens lots of times. Mouth breathing kids that can't close their mouth when they sleep in the evening, so their sleep's terrible. They don't go into REM cycles to get growth of thyroid hormone secretion from their hypothalamus. And then what happens is they wind up having no growth for their teeth to work with because they can't touch each other. They can't stimulate the dental growth plates in the jaws without dental stimulation. So the mouth's open, the lower jaw and the upper jaw are doing their own thing, and that's largely genetic. And you can look at the parents and you see who gave them the nose and their jaw, and then they got to live with it. And their neck has to do a lot of the work. Why? Because you can't sleep on your back well. So you want to sleep it on your side, wrapped around a pillow with the SCM and the trapezius sort of held to hold the left to hold the bag. The top shoulder is not getting supported by a big pillow, so you need one in front of the shoulder. The bottom shoulder is wrapped around a pillow, and that shoulder needs to go up because it's down all day long, and it needs enough support of the head so a pillow is high enough to keep the head supported so the SCM's not wore out. Otherwise, we get this posterior occipital pain pattern on the same side the jaw hurts, the same side their face hurts because their nose is causing pressure on that side. So then you have a hemicephalgia that usually spreads sometimes in front of the back of the head because V1 goes where C3 goes to, V2 goes where C2 goes to, and V1 goes where C3 goes to. So what happens is you get this mirror headache. And it's one of these kind of things you just don't understand until you sort of read the textbook and then understand, okay, that's why it hurts here and here in the front of the back of my head. And also, that's why more than one thing can lead to a headache in one zone. For example, a bad tooth and a sinus infection, which can happen a lot. The maxillary molars can certainly leak into your sinuses and give you a double whammy, and that patient's going to have a heck of a headache in V2. But it could just be one, both can combine to break that seal of that zone of the TCN easier, and it usually causes pain to sort of spread to the other side because they're basically meeting at the same place. They become two mad toddlers on a school bus, waking up the whole head. And then once that happens, you break this threshold, and then depending on how bad it is, the threshold gets broken more upstream and starts flipping a few more lights on, things like dizziness and hypersensitivity of senses, and then emotion of a headache, which makes it a bandwidth hog. So what activates that process is lighting up the circuit board enough with a molecule called calcitonin-related peptide. It's the neuroinflammatory quarterback of the body, works peripherally and centrally, and exists all over the body in two forms. In the gut is beta, and then the peripheral is alpha. And it's an acute phase reaction made to respond to toxin and injury, but it gets lit up every time we get a headache and keeps the lights on. And nitric oxide and glutamate are also components, and acidosis creating an ADP um, excess. And those are the things that activate the brainstem. But those things are hard to fix, except for now have drugs for CGRP. We don't have one for pituitary adenylate cyclase yet, but we're getting one, hopefully. So that'll help us control the activation phase. Then it's what happens afterwards is a hot mess because you're going to your brainstem, thalamus, and hypothalamus, and you're activating dysregulation in these areas by just turning on a lot of excess stimulation. And then it turns on the RAS in the limbic system, and then you get an impression of what this feels like in your cortex. You remember it, and it becomes catastrophizing. Everybody thinks, "Oh God, this is going to be a 3 days of I can't live the life anymore." And so there's almost a PTSD that happens with migraine patients, and this makes sense because it's the way it works neurochemically. And then the sympathetic and spinal reflexes also get amped up. And so we need a way out of this. So the nerve block algorithm I use, suspect migraine, start off with an SPG AE. We've already looked in the nose and anesthetized it, and you might as well block them. You can certainly scan them if you have an office scanner. That way you've completed the whole sinonasal headache evaluation. If it's not better, don't always assume it's a brain tumor, but you want to get an imaging study so have the neurologist look at them if that doesn't work. But then you can go on if you feel comfortable doing auricular temporal and occipital blocks because that usually finishes the deal. Because if you've turned off the lights in the front and the back of the head and it's still hurting, you need your head examined, both neurologically and also with an imaging study. So this is how I do it. You basically prep the nose with lidocaine and Afrin. You wait 5 minutes, and during that time, you get busy. You evaluate the patient's head. You start palpating where their occipitals and auricular temples are behind the jaw to see if those things are actually sort of hot fuses. And then you start talking about what you can do and just act like you're the waiter at the restaurant. You're not trying to tell people I'm going to do this. You offer it to them because this is a lot. And they sometimes need to go home and read what's about, and then they can come back. And I usually set aside a dedicated time to do the redos and the ones that want to come back for one morning. And then while you're doing it, you get just good at it by having your nurse prepare the lidocaine pledges for you, put them on a gauze, and you're ready to go. Give the patient a lollipop and some stuff to read about it, and if they want to watch a video, I've got one. And then you just get a camera system and scopes like most people have and use it. And then these are the places to palpate: V1, V2, the auricular temporal, the pterygoid insertion point in the back of the jaw, and the 2 points in the back of the head, the 1/3, 2/3 point between the nuchal tuberosity and mastoid tip. And so then you prepare them up with these pledgets. You can use ones with strings on them if you're worried about them aspirating or swallowing. But I've done over 7,000 of these things, and I haven't had one aspirator and get close to it because you don't use a lot of lidocaine. You let it sort of elute on a gauze so it's not too sloppy wet. So these are the targets we talked about. This is how you do it. You place
Place
it
it
here.
right up high in the nasal vault, about as high up as you can get it, just at the level of the head of the middle turbinate. And you'll place two of them in there because it's easy, and that way you can get a good block.
Because it's really easy to do. So what you just got to do is recognize
Place it
this is something we
right
need to.
up.
This is But you just do the SPG the same way. I didn't record the volume of that, but this is what I do: is I place this pledge sort of in the crotch between the middle infraturbinate and hugging the septum until you reach a point in that sort of blind sort of crevice of a little resistance. And it's either a spur, it's a rostrum. You can usually tell by how deep you are. And then if it's the rostrum, just I mean, it's a spur, just stop because you're gonna have another chance at the end of the block to actually use in a cadaveric nose, and then you can usually finish the job. I call it a two-putt because sometimes you got a dog leg you got to get around because that spur's in the way, and that we will not ever be able to traverse with a stenocast. So that's why there's a limit. And then once you get a nose that's numb and open more, then you can go sort of just replace it a little bit higher up, or if they've sniffed it back and you've lost one in their throat, they swallow it. It's not a big deal. It's a nominal amount of lidocaine, but if you want to use one with straws or offer it, I mean strings and offer it, you can always do that. Then you say, okay, where does it still hurt? Does it hurt behind the eye, up the forehead? No, those are good. Okay, you're good. If it still hurts in one place, then check the pledges. If it's not there, then you start feeling around the head, TMJ and the occipital points. And if they're hot, then you offer a block. And if after that's all done, or if you just doesn't, if you worry about anything that's suspicious for any kind of dangerous headache, new neurologic sign, worst headache of your life, new pattern, something just doesn't smell right, get an MRI and see neurology. So that's all we're doing is rebooting this nucleus. It quiets the system. And the thing is, it works fast because neurotransmitters have millisecond half-lives. The pathway of convergence tells you how to sort of know how this works and what to look for, and what you reset upstream and downstream is very impactful. So here's where you put the block for the auricular temporal. Here again, I use buffered lidocaine. That's 1 to 10 dilution of epi- uh, uh, 2% or 1% lidocaine. You can place it right in front of the rear of the helix, just over the zygoma. It's palpation tender. Just aspirate there so you don't get the veins usually where you're going to hit if you hit anything. And you're using a small amount anyway, even if intravascular should be nothing close to a anesthetic toxicity issue. And then half a cc. And then over the bone, and occasionally get a facial nerve weakness on that that's temporary, just because sometimes the nerve is, particularly in thin people. And then you, because using bupivacaine too, which is a little better for motor nerve block. So occipital nerve blocks here again, 1/3, 2/3 point between mastoid tip, nuchal tuberosity. Here again, you're going to use just half a cc. You can aspirate if you want to, but the vessel actually is between, not over either one of those. And then you can have a third occipital, which is usually I see with patients that have posterior neck surgery where there's possibly a neuroma, and then occasionally the great auricular here is just the anterior branch of the lesser occipital, and sometimes you need to get that done to completely unlock the neck a little more further down, and that's usually where you get the scalene muscle that's tight on that side. It gets released. So here's my experience. Over 7,000 blocks, you learn something. Who to target and how well they work. So this is what we looked at. We did a pilot study, 161 patients. Demographics showed they were largely female. It was early in the COVID pandemic, and they were older, more like the long COVID cohort. And these are pretty severely impacted patients, excuse me, with frequent symptoms. And these patients, 50% of them are migraine naive. And then most didn't come in for the headache. Only 24% did. And most of these were patients who thought they had a sinus infection, dizziness, or ear pain. So this is the numbers. As you can see, sinus headache the same, vertigo and ear pain right below it, and tinnitus right below that. And we had some smell patients. Then we followed this up with a little bit of a more depth study, 3 phases, looking at the effect of COVID, getting more expanded associated symptoms to sort of add to the interest, which really tells you the cool stuff that you can fix too. And then, of course, really assessing them with a better measure for their severity. And we found these were very effective. If you just did an SPG after you got good at it, 87% of these patients are better. Over 95% if you add on occipitals and I didn't even study the temporals at that time. And so we can get 15 weeks on average. Some of these patients get 6 months almost, and it's really a good thing. And I've had some patients get 2 years. And the occipitals add on, the temporals add on, and the duration adds on the more you do it. And so this is impactful because these patients have a lot of associated symptoms. They have brain fog, a lot of them. Bad necks, bad nose and jaws, as we talked about, but they have a lot of vestibular symptoms, auditory symptoms, hormone exaggerated orthostasis, and there are a lot of airway patients. So I got snoring and sleep apnea. And then these patients have a lot of triggers. Their neck is number one most of the time, particularly the older patients, and with the screen generation especially. And then they also have weather triggers as well as the jaw and the neck and the components we talked about. And these are severely impacted patients. 83% of these patients are either substantial, severe, disabled, cohort. Really pretty bad. And so you need something pretty good to help them. So this is a great tool because it does 3 things. It tells you something neurologic. It tells you probably where they're coming from and the other associated symptoms going with it. This also explains them too because they go away right there. It's okay. Well, there's an answer. But now what is causing it specifically may be more difficult to prove. And that's where neurology can throw their hand into the ring. But really, it just tells you where the pain is coming from that you can do something about the front and the back of the head or both. And so what you do is you try it. And you see it's a very valuable tool, especially with dizzy patients, because after a halt bike and romper, you don't have a lot unless it's something obvious. And so it gives you something to try. And it really tells you a lot because these patients will move their head up, look up, side to side, stand up, and lean over and pick something up and turn around. Those are the things I have them do afterwards and before. And you see a dramatic improvement right afterwards. And their ear pain's better. And those are the TMT patients, the adult patients that come in with recurring ear infections. Neck pain, same thing. They may have a trigger point thing as a lymph node, and they have pain in the back of their head. And then, of course, these other things, the strange ear symptoms we talked about, the olfactory, and a whole bunch of other neurologic stuff that's really interesting to see what gets better as well. You ask them about it, makes it fun. And then you do more. The more you do, the better you get, and the better your patient gets. And the more you do in return, they also get better for longer. So you don't have to see them as much because this gets labor intensive, but it's not bad because you can teach your PA how to do it, or your nurse practitioner. It's not hard to do. So take home concepts, neurologic stuff where it requires processing speed, memory, balance, video games. They crash with migraines. 2, it could be other things too. You can have demyelination, happens at the same time sometimes, but have that neurologist look at them and get an imaging study if it doesn't look right. Remember, anything that makes you amped up sensory-wise is probably a migraine state. And then every sense can have an aura. It doesn't have just to be light and sound. It can be motion, it can be smells, it can be actually the feeling of your skin. It's called allodynia. And then the SPG block is a really good reboot for the mood and neurochemistry of your brain. It reboots your serotonin, which, by the way, reboots your melatonin for the insomnia patients, and those are usually chronic pain patients, patients with painful days more than 2 days a week. That's what it takes to chronify the pain regulation of a brain. Chronification is a big deal. That's when you get nociplastic pain, bad neuroplasticity, and we need to stop that from happening by addressing these causes so they don't become in a tough spot. And then nitric oxide also drops, and you also get a drop in norepinephrine glutamate, by the way, which is exactly what happens when your estrogen drops. So the patients who are on fertility, PMS, premenopause, this helps them too. But they have to see their gynecologist to get their estrogen reeled in. But they can't get reeled in if their brainstem's dysregulated. So this helps that part. The headache's not always present though for the older folks because the older folks are dealing with pain all the time and they're sort of overwhelmed by it. Maybe their knee or hip, but their neck's probably always killing them, and that's usually what triggers these patients. So in conclusion, they're very effective and we should be good at it. They mimic a lot of the things we see, so we're going to see these patients a lot, and they're very helpful to help figure them out. And we probably can do them better the way that this I'm doing it because of the way it is. It's cheap, it's easy. We're doing them. You don't have to delay because you don't have to pre-cert a nasal endoscopy for Medicare, Medicaid, or insurance to pay for it. And we're not injecting anything, so it's not invasive. And we're not using a lot that cost anything. So lidocaine and the value, the cost of the local both syringes, $5. Not a lot. So, it's not a big deal to get it done. It's just wanting to do that because otherwise they're coming. And these patients are notorious migraine triggers. So there's a lot to learn, and here's the way to learn it. Look at the videos I got, more literature I have on my website and on YouTube. Thank you.